Yeah, it's my pleasure now to invite Dr. Poornachandra from Narayan Netralaya, who's going to talk to us on clinical interpretation of electrophysiology.
So, good morning, everyone. I would like to thank Rajendra sir and AIOC for giving me this opportunity. So, before he connects, how many of you made an attempt to read about ERG? Honest? No. Fine. Huh? Fine. I know, like even as a postgraduate, even I did the same. So, this is something which used to run away because somehow we are not comfortable looking at the waveforms. So, we feel confused, and we always assume that this is something recent advance. I will read late during the exam and all. But this is not something which comes under recent advances. This technology is there since very long time, and irrespective of the like some of you are going to become specialist in various things, cornea, glaucoma, retina and all. So irrespective of the specialty you practice, ERG is something which everyone should know. So from exam point of view, just concentrate for next 15 minutes. You'll be able to write in theory and you'll be able to answer whatever that's been asked in the Viva, the spotters, and some of you might attend interview for retina fellowship. There also they might, if you answer well about other things for extra marks, they may ask you about electrophysiology also. Fine. So what is ERG? It's the mass response of the retina to a luminance stimulus. Simple. Just stimulate the retina with light. What happens? There will be biochemical and ionic changes in photoreceptors and RPE, which generates electric potential, which is recorded as electroretinogram. As simple as that. Stimulate the retina, action potential gets generated. That's what you're recording it as, electroretinogram. Just like in ECG we have PQRS, here also we have A wave, B wave, and oscillatory potential, and sometimes C wave. A wave is from the outer retina, that is from the photoreceptors. B wave is predominantly from the bipolar cells with some contribution from molar cells. And along the ascending limb of B wave, you can see some small deflections over there. That's what we call it as oscillatory potential. And these are from amacrine cells. So your Viva ends here. Most of the time, most of the examiners, they won't go beyond this. If you answer this much, it's okay. But if you get a theory exam and all, if you have to write some FRCS exams where there will be MCQs, where they give spotter, they expect you to answer little more. Fine. So there are different types of ERG. One is full-field ERG, which is the response of the entire retina. So the pattern ERG, which is predominantly from the posterior pole, and multifocal ERG, where we check each and every point on the posterior pole. So don't get confused. There are different types of ERGs. So this is how a full-field ERG printout looks like. So the whatever that is in the blue is normative data of that machine, and the black waves belongs to the patient. Fine. So let's understand each and every waveforms. So before we do a full-field ERG, we need to what we should do. We should dark adapt the patient for minimum of 20 minutes. He has to sit in pitch dark room with eyes padded. During these 20 minutes, if there is exposure to some light, you need to repeat all that again. So basically what are you doing here? By doing this, you are silencing the cones. So only the rods are active. In that dark adapted state, if you stimulate the retina with a very small intensity of 0.01 candela per centimeter square, what you get is a predominantly a rod driven response. Clear? There is no contribution from cone here. And once you increase the intensity of stimulus, the A wave also starts appearing. So the cones will also start contributing. This is what we call it as combined response. Okay. So after that, we light up the patient for minimum of 10 minutes. We'll ask him to sit in an ambient light. In that state, if you stimulate the retina, what you get is predominantly cone driven. I'm using the word predominantly. I'm not using the word only. Predominantly cone driven response. In the same light adapted state, if you stimulate the retina with 30 Hz flickering light, it is only cone response, because for such an high frequency, rods can't respond at all. So understood? We started with an isolated rod driven responses and ended with isolated cone driven response with a spectrum in between. So whenever you look into the ERG, that's all you need to look. Whether the rod component is affected, whether cone component is affected, whether both are affected, are there any negative waveforms? That I'll come to it later. So clear? Any doubts so far? Nothing. So that's what I was telling. Just look whether rods are more affected, cones are affected, both are affected, or any negative waveforms. So now that is about the full field ERG, which is the response from the entire retina. Now coming to the pattern ERG. So this is the response to a contrast, that is checkerboard. So what did we use in fulfilled ERG? We used a luminance stimulus, that Gans fold. Here we are using a checkerboard. Okay, so don't get confused with the pattern VEP, that is different. Okay, so this is pattern ERG, and there is no contribution from the peripheral retina. I told you, right? This is predominantly from the posterior pole and the macula. So here also we have some waveforms. The first positive deflection, the prominent one is the P50, which assesses macular function. And there is a followed by a negative deflection, which is N95, which is for the assessment of ganglion cell function. Basically, it complements the VEP to distinguish between a optic neuropathy and a maculopathy. If you have a patient where some macula is affected, the P50 will be low. The N95 could be normal. Similar way, it complements the fulfilled ERG, whether the disease is localized to the macula or it is a generalized thing. For example, if you have a lesion at the macula and you do a fulfilled ERG, if it is normal and pattern is abnormal, that means it's indicating it's a localized disease. Okay, so I'll give you an example. You have a patient of advanced glaucomatous optic atrophy and you do pattern ERG. What will be the findings? What will happen to P50? It will be normal because macula is normal, provided it does not have any other macular pressure. What will happen to N95? Reduced. Okay, let us take an example, advanced age-related macular degeneration with geographic atrophy. P50 will be low. N95 normal will also be low because macula has to get stimulated for the ganglion cells to fire. So that's how we interpret. So then comes multifocal ERG. As I told, to detect even small foci of retinal dysfunction, we stimulate multiple points on the macula. Okay, so we use either 61 or 103 hexagonal elements depending on the area and the finer with what we stimulate the retina. The each and every light point will go and stimulate the retina, and we'll get a waveform corresponding to each and every point which gets stimulated in the macula. Okay, so that's how we detect even a small foci of retinal dysfunction. Where do you use this commonly? You must be getting a lot of reference from your rheumatology department, right? In HCQ toxicity, mainly in drug toxicity, or any case where everything is normal but the patient is complaining, the only thing which can tell us the answer is multifocal ERG. So that's about the ERG. Before going to the case example, just a couple of slides on electrooculogram. Sometimes it may come as short note or a long note. So I don't know, the pattern has changed now. The question, I don't know how it is. Still that short note and long note still exists? Just 10 marks thing, no? Fine. So electrogram, basically it measures the potential difference between the cornea and the Brooks membrane. Normally it's 5 millivolts because eye is the closed structure with so much of electrical activity happening inside, because of which it will have some resting membrane potential. That's what we are measuring. That's what EOG is all about that. So how do we do that? We give two targets to the patient. We fix two electrodes, one near the medial canthus, one near the lateral canthus. Okay, so and ask the patient to look once to the right side and once to the left side. The polarity changes, right? Because of the change in polarity, we get a waveform like this, which has got a dark trough and a light peak. Okay, and if you calculate the ratio, what is it called? Ardence ratio. Okay, so normal it is 2:1. If it's less than 1.7, it's abnormal. And whatever, how is this base resting membrane potential maintained, which is the layer which is responsible for this? Retinal pigment epithelium. Okay, so whatever the disease which affects retinal pigment epithelium in isolation will affect electrooculogram. Fine. Coming to the case example, this was an 11-year-old male, blurring of vision. Vision was 6/9. The timer is not showing here, so you can stop me whenever it's complete. It's not showing here. So 6/9 vision, born out of consanguineous marriage. He had this kind of a lesion in the macula, some yellowish deposit, and this is the autofluorescence test, and this is the OCT. What is it? This is like a spotter. 9-year-old. It's not CSR. Yes, exactly. Best disease. Okay. So let's do ERG in this patient. Let's see what's going to happen. Look at the fulfilled ERG. Go by order. What did I tell? First, look at the dark adapted responses. It's normal. Combined response, normal. Light adapted response is also normal. Now look at the EOG. We were supposed to get a peak like this. It's not there. So this is classic of Best disease. A normal fulfilled ERG and an abnormal EOG. Why it happens? Because Best disease happens because of the mutation in a gene called bestrophin, which is localized to the retinal pigment epithelium. Once this gene is mutated, the retinal pigment epithelium cannot function normally. So EOG is from RPE. So that's how the EOG gets affected in BEST. So this is the full family. The father was asymptomatic, but when we called for the screening, he did had some lesion. So whenever you diagnose this hereditary retinal diseases, you should always screen the family members. So this patient, we did a genetic testing, had heterozygous mutation in BEST1. So this is second one is a 10-year-old male born out of consanguineous marriage, 6/18 vision. This is the fundus photograph. So the yellowish lesion which you saw in previous photograph, which was limited to the macula, now we can see there is an extensive distribution beyond the macula. And FFA was also showing some leaks, staining and all that. I'll show the autofluorescence now, which clearly delineates the hyper autofluorescent vitelliform deposit. Last case you saw, it was there, some present only here. In fact, this was referred to me from UVA department. This patient was given multiple steroids, immunosuppressants, AC tap, antiviral, you name everything he had taken, because they thought this is kind of an inflammation. And OCT also looks like an inflammatory disease. This is a subretinal fluid also, and there is intraretinal fluid also. Last case, what was there? Only subretinal, right? This has got intraretinal also. Any guesses? If you answer this, not gold medal, some diamond medal you will get. Fine, anyway. So this is a case of autosomal recessive bestrophinopathy, which is a new entity. Okay, I'm showing you this because you may come across these kind of cases. You should not misdiagnose. The first case what I showed was a BEST disease, that was a dominant BEST disease, where only one gene was mutated. This is a recessive disease, where both the genes are mutated, because of which disease is relatively aggressive in these cases. Okay, fine. So look at the ERG in this case. There's a gross reduction in amplitude. And combined response also same thing. Even light adapted responses are affected. And EOG is almost now unrecordable because there is no functional bestrophin gene. So both EOG and ERG are abnormal. If only is one abnormal, that is dominant BEST. If both are abnormal, it is recessive BEST. And clinical features also accordingly will differ. So this was a 10-year-old female, 660 vision. So there are some atrophic macular changes. I know screen you can't make out clearly. Born out of consanguineous marriage, see the autofluorescence. Now we can make out the atrophic clearly, and there are multiple flex-like deposits. Excuse me. Fleck-like deposits over here. So what is the diagnosis and what's happening in the OCT? Outer retina is completely thinned out. Macular atrophy with multiple flecks. Spotter, this is easy. Someone told. It's a Stargardt's disease, yes. So we did ERG in this patient. So now look careful. These are the typical printouts what you get in exam. What has happened to dark adapted responses? The wave was supposed to start from here. It's starting from here. It's delayed. Look at the amplitude. Amplitude is also grossly reduced. Same thing is happening in the combined responses also. The wave was supposed to start from here. It's starting from here. Amplitude, instead of going till here, it's stopping here itself. Okay, so the rod component is affected, the combined component is also affected. Now look at the light adapted. The wave which was supposed to start here is starting here. So the latency is delayed, amplitude is decreased. These are the only two things you need to look. The latency, that is the onset of waveform, amplitude, which is measured from trough of previous wave to peak of wave of interest. Okay, both are affected. So what does it indicate? You should just tell it indicates cone rod dysfunction, that's all. Diagnosis could be anything. So whenever you read an OCT, go by order, tell the findings, could be suggestive of so and so. You should always give it differential. Don't, I saw you people doing when sir showed one OCT, you suddenly told CSR. So don't do that. Whenever you been given an like imaging entity or anything investigative, go by order. So you will have an advantage. You will take a lot of time to answer. So you can avoid unnecessary question which you would not have read. And examiners will also be impressed when you go in a methodical order. So this has a cone rod dysfunction. So what is the use of doing ERG in Stargardt? You must be asking, sir, it is a Stargardt disease, there is no treatment. Why are you doing ERG? Because Stargardts can be of three types, 1 minute, depending on the component of receptors involved. If it's a full-filled ERG is normal, means the disease is limited to the macula, the chances of progression is nil. If only cone component is affected, there is 20% chance of progression. If both cones and rods are affected, as in our case, there is 80% chance of progression. In this way, in a way, we can prognosticate also. Okay. I'll just skip few a case example. I'll be just outside in case if you want to have only 1 minute. Okay, this case had a photophobia. Fundus appeared normal. So there's a small cavitation over here. Can you see? So what could be the diagnosis? We can see these cases of photic retinopathy, laser Bunsald. Even that's what I thought. But when I did an ERG, look at this. Look at the dark red responses. Completely normal. Look at the light adapted responses. It is undetectable. So the lesion is such a small lesion at the foveola, but the ERG is telling the cones in the entire retina are non-functional. So this is a case of achromatopsia. Sorry for the spelling mistake. So it is a type of stationary cone dystrophy. That means it's non-progressive one. Okay. Then, okay, so that's it. I think I'll have to end here. So always remember, so any investigative modality, don't take it in isolation. It has to be correlated with other imaging modality, as Giridhar sir was telling. And also the history and the clinical examination is very important. Okay, so all the best.
Thank you, Poornachandra. Fantastic talk. Very clearly explained. This is not a topic